Hi, welcome to Habitual Excellence. I'm Mark Graven. We're joined today by Rochelle Schultz. She is the president and CEO of Winona Health in Southeast Minnesota. So before I give a little more formal introduction, Rochelle, first off, thank you for being here. How are you?
Oh, it's my pleasure. Thank you for having me and looking forward to our conversation.
Yeah, me too. There's a lot we can cover. Rochelle has been president and CEO since 2002. So that's been a really good run, hasn't it?
Yeah, yeah. I think it's a little bit more unusual to see that happen these days, but it's been really great. It's been
Yeah.
really great.
Well, good. So, Rochelle is, again, president and CEO of Winona Health. They are an independent community healthcare system. Winona Health has been named a top 100 rural and community hospital for the past 3 years. Is three step four? Okay. I was about to ask. So it's been 4 years now. Congratulations.
Yeah, thank you.
Rochelle graduated from Georgetown University with a BA in economics. She earned an MHA at the University of Minnesota and received her interdisciplinary doctorate in education and leadership from Creighton University. It would get confusing in your workplace, I guess, if we called you Dr. Schultz.
Yeah, that's usually more an external thing sometimes, but yeah, it's. I say not that kind of doctor when somebody asks me to, do
Right.
something.
Well, and there are many kinds of doctors, but it does
Yeah,
get
yeah.
confusing. But so, first off, Rochelle, I'm always curious, especially from an executive standpoint, what was your first exposure to lean practices, management ideas? What's your recollection of that kind of personal history that you have?
Yeah. I would say, I think I'm sort of an individual that's just sort of wired for continuous improvement. I'm always sort of like, okay, this can be better, or this isn't working, or how do we change this, and so forth. And, when I came to this organization, so healthcare has lots of regulations, we got lots of accreditations, we have all of those kinds of things. And they all serve a purpose, but I guess I really was looking for like what's better than that. What can elevate our overall performance that comes more internally, like we want to do it because it's important to us. And we had just gone through a joint commission survey, here, and I've done those in the past, and I always feel like that goes a little bit of the way, but it really isn't deep into the roots of the organization and really getting us where we want to go. And right after that, I had been introduced to the Malcolm Baldrige criteria. So we started a path, working that which, my medical staff here, my leadership team, the rest of the staff, everybody, really embraced, because it was like, okay, like we get to define this, and we get to strive to be better. And so we did that. We have a really great program in the state of Minnesota. And of course, there's the federal program. And we did that for a few years, and then we got stuck, and it was in process. And like we're nailing all of this other stuff, but we just didn't get our arms around process. And I was thinking about that and thinking like, okay, who can teach us process? Who can, who are sort of the experts with this? And sort of in the back of my head, I know I'd heard of lean. I know I had read something about it or heard somebody speak about it. Probably in my master's, program, there was, some operations thing that talked about lean, things like that. So, I did some, looking around, and we have a couple of universities in town, and went over and talked with them, and they did have some folks that, were looking to build, a little bit more along the lines of lean programming and understand process improvement. Um, so we did actually a grant with them, and we did that work. And that still to me was scratching the surface. It was learning some of the tools, but not the cultural work. Cause I kept thinking like, we still got to go deeper. We got to go deeper. And with another faculty member, met an individual who was really steeped in lean and had not worked in healthcare, was working more in the airline industry and, in a few other areas, and brought him in. And that to me, it changed everything, because I started really understanding the robustness of it. And it wasn't just the process. I mean, that's the element of it, but it was all the pieces. It was the people pieces. It's the change management kinds of things. It certainly is the process, part of it, and mapping, and everything that goes with it. And to me, that's what pulled it all together in like a really integrated model. And we did it work with him for a couple of years, and then I asked the sort of the organization, are you in for this? This is a big deal. Are you in for the change? And everybody, because we didn't know what we didn't know, said, sure, sign us up. We'll do it. And then we started, and we haven't stopped, since that time. And that was about 2008. And we had, it was hard the first couple years, and it was more our mental models, that we had to break through, and the cultural pieces. The tools are really great tools, but you got to be able to use them and understand what you're doing. So yeah, in the end, it was just, I was looking for one thing, but I found what I didn't know I was looking for in a really robust manner, with really kind of our first sensei, who came into the organization.
What terminology do you use internally in terms of like internal branding? There's a lot of variation with this in healthcare. So you mentioned lean, but how do you label that at Winona Health?
Yeah, we call it continuous systems improvement, or CSI, and that's pervasive now in the organization. We used lean a lot early on. We had the Baldrige criteria before that. It just sort of all married together, really within the concepts of continuous systems improvement, and that's really held for a long time, and everybody really knows what that means.
Yeah, it reminds me of the TV show. I guess this would be CSI Winona.
Well, and there was actually, we did do that because I'm like, it's like, a forensic process. You got to get your data, you got to find root cause, you got to, investigate all of those things. So it really sort of suited us. So there was a play on that.
Yeah, that's a good point there. I'm curious if you can elaborate a little bit, Rochelle. When you talk about mental models, is there one in particular that comes to mind that was important to try to shift the mental model from whatever it was before to what you wanted it or what it is now?
I think one of the, really powerful components of, or understanding really of lean or this, process improvement, performance excellence work is, it's top down and it's bottom up. And so it's moving away from the old, your supervisor has to tell you what to do, leadership has to tell you what to do and or how to do it and when you can do it and all of those things, and giving up that control, and putting that in the hands of the staff and actually facilitating their work and their improvements and all of that, as opposed to being the person that they come to. That was a huge shift. Not everybody can make that shift, and not everybody did, here. But, I guess I think about, my own philosophy is that in this organization, I need 100% of everybody, rowing in the same direction to help us get wherever we need to go. And so it's not a small group, and none of us, is smart. I'm good at what I do, but what I do is not what everybody else does, and so forth and so on, to different roles. And how they all weave together, to make us really a great organization, to hit the top 100 and things like that. It's because everybody understands what they're doing and how they're doing it. But the role of leadership shifted in a really significant way. And I had people, of course, early on that were doing both systems, trying to, all the old legacy, reports and models and everything we had in place, and then we created this new one, and people were getting pretty stressed out, and I kept saying, I'm not asking you to do that. I'm telling you this is where we're going. I'm not going over there. So if you choose to do that, that's a pain process you're putting yourself through. And it took a leap of faith, I think, for a lot of folks. There were a couple of early adopters that just said, I can't do both. I am going to just trust it. You're going to have to help me. That type of thing. And, and they did it. And, all of a sudden it's a whole different kind of freeing, experience. But, it's tough to change leadership.
Yeah.
people get there for reasons, and to tell them like all those reasons don't matter anymore, and now we're going a different way is that's a really hard shift.
Yeah. And you're right. That is, it's a big challenge. It's not like flipping a light switch to say, hey, you're going to embrace a new set of mental models or behaviors. I mean, how was that for you personally as president and CEO of the system? Kind of trying to embrace that change or model the behaviors, or how would you explain that?
Yeah. We all have our ways of doing things. And yeah, I mean, it's kind of tough sometimes. You have to pick up a mirror and sort of look at yourself and go, and you start watching your folks and it's like, okay, wait a minute, they're sort of mirroring me. That's not working, and so then you sort of have to change. And I tried a lot of different things, and some worked better than others, in the shift. And I just had to find those things that like I could do it, so for example, even visibility, types of things. Instead of roaming the hallways or the areas in the departments every day and things like that, I did shadowing. I just scheduled time in different departments and, with different kinds of staff and things like that. So I could, hear from them and watch explain to me what you're doing and how you're doing it. And, what would make it better? How could you do this better? And so I could see and, like reflect that back even, with supervisors, how deep are we going into the organization? And if we're not going very deep, the blocker is leadership, right? And so having to go back and like do some coaching, with that. So, it kind of puts everything, upside down. But for me, the easier part was, and why I really enjoyed it is, I'm all about development of people. And so this was a way to like really reach deep into the organization and find opportunities for all kinds of people, to sort of elevate their ability to contribute, and grow. And that for me is that's a personal pride, kind of thing. I had some of that done for me early in my career. So I really enjoy that kind of work. And so then it didn't make that, so hard.
Yeah. Well, that's a powerful notion, that focus on people development. People I know, former Toyota people, describe Toyota as a people development organization. And I think that's where, as you've learned, Rochelle, and there are concepts, mental models, behaviors that are very transferable from a company like Toyota. Obviously, very different than an integrated health system.
Yeah, but we worked with Toyota for a couple of years.
Oh, really?
Yeah, we did. They came in. They actually it was their support center that's here in the States where they do a lot of that training. And, we were introduced to them and they were looking, to work with a couple, healthcare organizations. I think they'd only worked with maybe 2 in the past. And so, we had 2 projects, and it's really interesting. And I think it's the power of like getting outside of our industry also is, that's one of the things I really enjoyed doing a lot when we got into lean is I got a lot of manufacturing in my community and I've been in most of those operations. And whether they call it lean or not, they think differently, they move differently, and just learning those kinds of things and how does it, how can we apply those in the service industry? And I think it was great when Toyota, we had, folks coming in and, that were, sort of our mentors and working with us because it wasn't easy, they're very challenging about like, why are you doing it this way? And we think we're, like, why don't you know healthcare? It's very complex. We had all our reasons. It's complex and it's hard and you just don't understand it and all of those kinds of things. And why aren't you holding, your doctors accountable? And by God, they should be, and I'm like, okay, well, we have to think about how we were to approach them. We have those conversations. But, that energy that comes in, it's the stuff that, we have to sit back and reflect on and listen because we're so close to it. And I think our industry is, it's a bit hamstrung, with a lot of stuff, old legacy things. We're not always really great about being, I think a lot of us say we want to innovate or we are innovative or we're entrepreneurial, but it really kind of devolves down into, well, it's a regulation. We don't get paid for it. We don't do this. We don't do that. and healthcare seriously needs to have, a reboot, in some sort. So I think, folks with those kind of fresh eyes and that experience, coming in and really challenging us, we continue to this day to use many of the tools that they taught us, some of the language things. Once we kind of got to a meeting of the minds, I think, back and forth, you just have to keep having those conversations till the language is like meeting in the middle, and you both know what you're talking about.
Yeah. And I would invite the audience to go look up that Toyota group is called TSSC. Their website is tssc.com. And in recent years, they have published some really amazing videos on YouTube. I think of working with an eye clinic as part of the UCLA health system and reducing waiting time for treatment, like literally saving people's vision by reducing those delays and improving access. They did some work with Children's Health in Dallas around preventing infections. And, it seemed like and those videos illustrate the model where it seems like they challenge you to think through it. They're not coming in and saying, move this here, do that there. They're coaching and facilitating and modeling that, it seems. That comes through very clear.
I mean, they were new concepts to us, and we had to ingest that and then really think about, like, okay, like that's going to flip a lot of things. It's going to flip scheduling. It's going to flip workflows, which is what happens, when you do this work is you're creating better flow. It's just their approach was different. But it was really good. It was really good for us to be disrupted that way.
Yeah. So speaking of disruption, going back almost about a year ago, starting to realize that things were going to change, and COVID was becoming a reality. How did what changes, if any, did that precipitate, Rochelle, to you as president and CEO, or for leadership in general at Winona Health? These new challenges of COVID, how did leadership change, if at all?
Yeah. Well, as soon as, we were tracking in the early days, like, is this coming to the U.S., all of that, sort of watching things. And, it was in March when our incident command, when we activated that. One of the things, hospitals do is, we do a lot of planning, emergency preparedness, things like that for all kinds of events, and do mock drills and whatever. So obviously this, wasn't real, but I think all of those plans being in place, what you do is then you sort of execute those plans, you pull them up, and then you craft them around, what is the state of the state. I think what was, this has been I think a tremendous year of learning and sort of exposure, of gaps and issues and how quickly can you do, like, rapid cycle improvements, how quickly can you respond, and change. So, we first did all of our, the planning piece, which is, if the surges are going to come, which was all of the expectation, sort of watching what was happening on the coasts, then how are we going to surge our hospital beds? The PPE shortages were already there. The testing supplies weren't there, all of those kinds of things. And, and planning for all of that and understanding what the limitations were and so forth. So we get all of our plans in place, and then it's kind of a hurry up and wait, because then you need to, have an action. I think one of the areas that became where all of our kind of prior years of training and how we work and what's in our culture that came to bear was the very first positive that we had in our community was in a nursing home. Now, of course, today we all know what happened in nursing homes across, the country. And at the time there was no visibility on that at all. And in fact, with testing, with the limitations, we're told you can only test like ICU patients in the hospital. and then in the nursing home only if they're symptomatic. And so we're already behind, by the time somebody's showing symptoms. And, and we knew that this was a fast spreading thing. So the first person, in the nursing home shows up and is positive, and this is one of our community nursing homes. And then daily, every day, more and more and more. And we had a medical staff task force looking at this, and we were all frustrated with the limitations that, the state had put on, with the testing. And, we had a conversation around, we don't even know what we're dealing with. We have to get in front of this. We need to go and test everybody in that nursing home, the staff and the residents. And so we just did. We just took what we had, even if it was limited, and we tested everybody, and we found 26 more people who were positive. So there's this hidden disease out there that, is just rapidly, spreading. There were, 14 residents in that nursing home that were still negative. And immediately after that, we went into action here. We took a wing of our nursing home, cleared it out, made it a quarantined wing, had our facilities people went in, did everything that they needed to do. Our housekeeping people did. They planned for everything. And, the CDC came to see what, we were doing. And we moved those residents over here because the goal was we have to give them the best opportunity to not get infected, because there was a high mortality rate, of folks at that time. And we moved them all over here, and we worked with the families. We had to work. This is actually a community thing because people were afraid we were bringing that disease, into, our facility. But in the end, those people didn't get infected, and 30 days later, when that nursing home, it had all kind of cleared out, they all moved home, and, and it was a good thing. So, but you have to, it was all of those very fast things. How are we going to, feed them, medications, staff it, work with the other nursing home, the billing for all, everything. And very quickly, this is what that, kind of muscle does, is it makes you do very rapid cycle, improvements, and it really worked well. And same with testing. Now we have the vaccine, and, we sit here ready and prepared. We could do thousands of vaccines a day, and we have no vaccine. So, right. This becomes that supply chain kind of thing, but running process and doing flow. And even as we were doing vaccines, we've been running that through, with our elderly folks in town, and the feedback has been that was the smoothest thing I've ever been through, and this was really great, and from start to finish. And that's of course what you want from any process is really good efficiency. But we practiced, the first day we only did 25 people because we wanted to see how the process worked. And then, you ratchet it up. So that learning is so steeped in people about, planning it out, doing it, finding your errors, or your defects, going back and correcting for those, and improving your process. And so we don't even think, we just do it, it's just part of what we do. And I watch across the country, and I think there's some of these hospitals and locations that, don't think this way. And I just feel for the staff that are dealing with this pandemic situation. And I don't know what kind of, structures they have in place really to support them in such a challenging time.
Yeah. You had 10 plus years of experience with Lean, with CSI, of what I hear you describing are new mental models that have maybe just become the way you do things now. This idea of starting with a small test of change instead of thinking, well, we've got the process, everyone in. Right. It's better to discover the hiccups at a small scale. Like, to me, that's a mental model of do the test of change, refine, iterate, and then, you can expand the right. capacity, at least as the vaccine supply allows at this point. Right. So that's really, really good to hear.
Yeah. Yeah.
So one other question, though, going back to, kind of leadership and mental models, you had talked, Rochelle, about the shift away from being very top down to being both top down, bottom up. And, I wonder when something like COVID strikes us and there's time pressure and there's urgency, was there tendency to shift back into top down mode, or were you able to maintain a good balance. I'm curious what that thought process was like of figuring out that balance.
Yeah, I think that we maintained, everything that we had in place. I think what changed, the role that I took, I think that which is always there, and I've done it, but I just accelerated it or broadened it a lot more. It had to do with communication, and so while I would have I have a level of communication with my organization in a variety of different ways. It became a daily communication, actually. Like, here's what's going on. Here's what we know. Here's what we're prepared for. Here's what this group has done. Here's what this group has done. Oh, we've got these equipment, have come in. Here's what we're talking about with PPE. Okay, watch for these things. Yes, we're doing visitor restrictions and in bite-sized kinds of pieces so that people could absorb, that information. And it was interesting to me because within, probably a couple of weeks, I was getting a lot of communication back from staff going, this is so helpful, thank you. And some people were actually passing it on to family members, other colleagues or other places, just because it was more information that was out there. Because I think in that pandemic, in general, communication is just critical. Like what's going on? What do we know? And what should we be doing? And are we prepared? And the same thing happened, I think with, the community. I did a number of editorials because, my goal was to bring anxiety down and just say, here's what we know. We are prepared. If this happens, we are prepared. And we've got, this equipment, these staff, we've got this, we've got your back, from a community perspective. And the same thing with the community. It was like, we need to hear that. And it didn't make it go away. But it just brought down the level of anxiety and worry and concern. So I found my role being really more of like, who are all of the different constituencies out there and the stakeholders? What does each need to hear? I had weekly calls with, my city manager and county, administrator, and we did it with all of the, area senior services. We just had all of these channels. My board, was like a weekly thing. So I think that particular event, it was a lot about communication because the staff knew what they were doing. The physicians knew what they were doing. We had channels of communication around clinical, interventions, things like that. What's happening in the community, getting that baseline out there. And so mine really became, just to channel this information and be very transparent about it to all of the different stakeholders.
Mm-hmm. Yeah. So maybe kind of final topic before we wrap up. You've shared a little bit of some of the process for designing the process for COVID vaccination. And I'm curious, are there other lessons learned that you would share or advice for other organizations of preparing for, hopefully now we get into a phase where supply constraints won't be the problem? And we'll have to think about the capacity for how many people can be vaccinated every day. What else would you add in terms of lessons learned or advice for others
related to COVID?
And in particular, thinking about the mass vaccination challenge that we have.
Yeah. In the end, so much of this is just it's process, and I think really laying out your process, ahead of time. And then as we talked, just you practice it and then you can start scoping it and scaling it a bit differently. There's, and we'll see, now, the current vaccine, we've had 2 doses. That's a little bit different than, other vaccines where you actually have to plan for that next step. And then when you start bringing in your seconds, how are you going to run 2 lanes, things like that. The newer one, if Johnson & Johnson goes through, it's 1 vaccine, so it'll be, or one dose. So, that'll make it a little bit easier. And I've watched, sort of like what's happening across the country, the drive-ups, the out in the parking lot kinds of vaccines, the arenas, these things compared to mine, which is a smaller community where, we have some controls in place. And, I see a lot of these things going on, but, there's also now feedback coming in that some people aren't coming back for their second vaccine. So that becomes an issue because those vaccines are predicated, their effectiveness is predicated on the two doses. And so, like, what does that mean? And then what are you doing with those vaccines? And, I think those are some of the things that come in the process, but we have to be pretty fast on the draw with those. Like, yeah, what does that mean? And how do we find these people? And how do we, complete that? But the vaccine in and of itself is not a difficult thing to give. I mean, certainly for healthcare providers, we do this every day, all the time. We had to think a bit differently with the Pfizer because of the cold storage and some of those kinds of things. But this is they provide plenty of information, and it's like standard work. You follow the standard work, and that works. So. I think it's, to me right now, I think our biggest issue is not having enough vaccine. And I think we're already, the mixed messages that are going out, like we're opening this up, to more people before we've reached the priority populations that we've already had. We've already skipped we already just threw out the process we had. And that to me is, just a little disheartening because I think we have a lot of at-risk people out there that we haven't reached yet. And I think, we need, and we're going to continue, on that as we get vaccine. But we have a lot of mixed messages right now across the country, and different states doing different things, which I guess is to be expected. But I think CDC was very clear. Here's the priority populations, and here's why. It reduces mortality and it reduces the spread. Really good reasons to stay focused on that. So let's get those done before we really take a limited supply and open it up, everywhere else. So, I think this is an interesting. It's not an experiment, but it's an interesting process to watch because it's brand new. I mean, we haven't seen anything at this scale. So I think it's really interesting to sort of watch and learn right now. I don't know that this will be the last pandemic we ever have. So we should all be taking really good notes, right now, so we do better next time.
Yeah, well said. And I'm guessing when you talk about possible confusion or anxiety or mixed messages, there's a continued role for you and your community, editorials, communication, reassurance, right?
Yeah, absolutely. I mean, there's, a lot of populations. How come, this organization has it? How come I can go, I'm on a border state. So how come, in Wisconsin, they have this over here, and in Minnesota, we don't. And so, yeah, it's still, again, just, people are so, and I get it. I mean, a lot of elderly folks have been in their homes since March with very little time outside because they're very fearful of getting it. They've seen what's happened, to friends, family members, other people. And, so it's a fearful time, for them. So, being able to just communicate and have them be patient, but when we can get them in, I mean, they're so grateful, and it just sort of breaks your heart, that they've had to, kind of make it through all of this, but, we'll get through it. And, but the messaging is really critical.
Well, Rochelle, thank you for your leadership there in Minnesota and at Winona Health. Thank you for being willing to share with us today. I think this will be really helpful for other leaders and other organizations. So again, our guest has been Rochelle Schultz, President and CEO of Winona Health. Rochelle, thank you so much. It's really good to be able to talk to you again. Thanks for being here.
Yeah, thank you, Mark. So such a pleasure to visit with you.
All right. Be well. Thank you.
Thank you.